welcome to the October edition of RDAR's seminar series. As a reminder, we will have a talk today from our speaker, Dr. Hugh Garavan, and folks can type their questions in the chat, and Hugh and the moderators will address these questions at the end. So please feel free to put your questions in the chat, and we will get to them at the end. So I have the absolute great pleasure of introducing Dr. Garavan today. He is a professor of psychiatry at the University of Vermont and an adjunct associate professor at Trinity College, Dublin. His work focuses on key factors in the development and maintenance of addiction. These are including reward processing and cognitive control. Dr. Garavan has really been at the forefront of this new wave of big data in addiction neuroscience. So, for example, as a co-creator of the Enigma Addiction Consortium, a site PI for the Imogen Project, and a site PI and associate director for the Adolescent Brain and Cognitive Development Study, and as a site PI of the Healthy Brain Child Development Study, he and his colleagues, their efforts have been responsible for aggregating or collecting probably over 50,000 participants by now, spanning from prenatal stages of development into adulthood. And so through all this, Dr. Garavan has published 380 articles, received numerous federal awards, and has recently created the Scientific Training in Addiction Research Techniques, or START program, which serves as a mentorship program for underrepresented scholars in addiction science. So today, Dr. Garavan is here to discuss some of his exciting work on the differences in brain and behavior that can arise from initiating cannabis use at different life stages. So with that, please, let's have a warm welcome. Even though we can't actually welcome anyone, I will extend the welcome for the RDAR community. A warm welcome to you, Dr. Garavan. Please, we can begin.
Okay, well, thank you, Nick. That's a very kind introduction. I feel like if I open my mouth, things are just going to go downhill. Maybe I should stop right now. For those of you who are submitting questions, Nick and the others have promised me that they'll filter out all the tough ones. So if you want your question to get asked, make sure it's a real softy one for me. It's great to be here. It's really nice to be meeting a whole bunch of people who haven't met before. So I guess we'll get into it. So the title here, sorry, I've realized just how horribly wordy it is, but basically the focus here is cannabis. Cannabis initiation, and what might it do to adolescent young adult brains. That's essentially the focus. So hopefully this will all work. There we go. The great thing about presenting to an audience like this is that you don't need much background. You're already very clued into all these issues. So the entire rationale for what I'm going to talk about, I'm going to compress into one slide. And here we go. First, adolescence, you all know this critical period of development, lots of interesting brain changes, personality changes, lifestyle changes, and so on and so forth. So adolescence is kind of key. So it's drug use experimentation and so on and so forth. So interesting period to study. Cannabis use, as you know, is still very popular. This is just from what last year's Monitoring the Future. You see there's a drop there in use levels associated with COVID, but the numbers are coming back up. So still very commonly used. As you all probably know, most joints are changing now. The ratio of THC to cannabidiol has significantly changed. So cannabis is much more potent these days than it has been. This, the situation across the world and in the US with regards to the decriminalization and the legalization of cannabis has changed. As a colleague of mine has said, these kind of regulatory changes are happening, prior to scientific consensus as to what, might be the risks associated with cannabis. And then finally, last point to mention is just the perception of how risky cannabis is has also gone down substantially over the last couple of decades. So the whole point of this is that it's an interesting topic. It was mentioned at the beginning there by Nick, the ABCD study. A big part of what motivated that study was to try to get a better handle on what cannabis might do to the developing brain. So, this is what motivates the research I'm going to present today. The last thing I mentioned, just by way of background, is this is kind of an old slide, and it's from a rodent model. But another reason why the adolescent period in cannabis might be worth interrogating is that the numbers of CB1 receptors increase considerably during puberty. So whatever effect cannabis might have, we already know this from other in vitro work, whatever effect cannabis might have on adult tissue, it's probably going to have a more enhanced effect on adolescent tissue, in part because, again, of this increase in the cannabinoid receptors during that period. So that's the question. So cannabis and its effects on the developing brain. And I'll just pause on this for 1 second. You all know this just as well as I do. Establishing causes and correlations in causes and consequences in human research is really, really complicated. Almost all the human research that we do is typically correlational. So we don't really know if we see a brain correlate, if it's pre-existing difference, if it's a consequence, if it's a correlate, but actually not meaningfully related to the condition at hand. Just to elaborate on that a little bit, the causes, the risk factors for use, and the consequence are very likely to be very many in number, very varied. Each may be weak in isolation, so that makes it challenging to identify these risk factors and consequences. Effects may be small. One of the things that are coming through from working with large data sets, as Nick mentioned, is that, true effects, so effects that we can properly cross-validate and replicate in these large data sets, they do tend to be small effects, especially in the neuroimaging realm. These effects might also be specific to subgroups of users, but our studies tend to be very underpowered, and I'm sure, most of you are aware that there's this whole kind of anxiety in our field, certainly in the imaging field, about the low sample sizes, the lack of statistical power, and the validity of prior results. So that's a consideration. Substance users and the groups that we use to compare them tend to differ on many confounding variables. So this is another thing that makes it challenging. And large longitudinal studies are rare. So it's a challenging landscape to try to come up with anything definitive about cannabis use and its effect on the developing brain. I'm going to start with an illustrative example. So this will not be on the test. So this is just a quick snapshot of a couple of studies, just to kind of, again, set the stage for how complicated this can be. So I'll go through this relatively quickly. But this is a bunch of years back. What is this, from 2015? We have a sample. This is from a study called Imogen, and I'll talk about this a little bit later. But within that sample, we identified 70 cannabis users. They were all 14. And we were to compare them to 70 controls. And this is back in the day when a sample of 140 was, significant and substantial for neuroimaging. But we were able to, look at these two groups, and they were well matched on, as you'll see there listed, sex, handedness, age, verbal comprehension, perceptual, reasoning IQ, puberty, socioeconomic status, lifetime alcohol, cigarette use, and sight. This is a multi-site study. So, two well matched groups. The task that we gave them is an odd sort of task. It's actually short video clips. These are just stills from it. So what you see is an actor doing something neutral. In this case, just sort of sticking his tongue out. I guess that's neutral. One could imagine that that's perhaps aversive. Another condition is they're sort of emoting anger. Again, for adolescents, these sort of, social interactions might be especially salient. And then there's a control condition. And what we did is we just studied the amygdala response to these videos. So very, very, simple kind of study. And what you'll see here is that, it's the same story for the left and the right amygdala, whereas, controls show response to the neutral video and to the angry video. The cannabis users show this, elevated response to the angry video. So interpret that how you wish. Is this some sort of hypersensitivity to threat signals? Is this, reflecting some sort of anxiety of the cannabis users? However you wish to interpret it, the big question just for present purposes is, can we conclude that this effect was caused by cannabis? Let's jump to another study. This, again, from the same Imogen sample, we have followed these kids for 10 years, actually. So we identified another group of participants who at age 14, so similar to the previous group, were all cannabis naive. But then a certain number of them by age 19 had gone on to use cannabis. And those are the levels of cannabis use by age 19. So all naive at 14 went on to use cannabis. All naive at age 14 and then went on to use cannabis by age 19. And I'm just putting up that distribution just to make clear that for this, and actually for all the research that I'll be talking about today, we are not talking about kids with cannabis use disorder who have extremely high levels of cannabis use. Here you'll see that, there's the distribution from just, 140 kids who just reported 1 or 2 lifetime uses up to, about 120 kids who report 40 or more uses. But anyway, back to the present story. What we wanted to do is look at that amygdala responsivity at age 14 in these cannabis naive kids and see if it is related to future cannabis use. And even though this is a little bit messy here, that is a significant linear function. So here we have now that baseline amygdala reactivity to these angry faces is predictive of future cannabis use. And then finally, just kind of part 3, what about the amygdala in those who were using at age 14 and continued using? So if you can see here, we didn't have follow-up on all the participants. We had started off with 70, we have 38 and 38 controls. This is that age 14 effect. That's the same result as before. The cannabis users showing this kind of hyperactivity to the in the amygdala to the angry videos, controls showing reduced activity. 5 years later, the controls show this increased activity over time. That seems to be normative. If we look at the hundreds of other participants, they show that same pattern. But we don't see as big an elevation in the cannabis users. We see, in fact, if anything, sort of not much change from 14 to 19. Again, you're welcome to interpret that how you wish. Is this some sort of, precocious development in the cannabis using kids? They're already at these more adult-like levels of responsivity. Is this some sort of self-medication that's stunting the, increased activity of that system going forward? Not sure. The point, and I realize I'm probably dwelling too long on all of this, is just with this very simple, single task, single brain region, we have evidence that amygdala hyperactivity characterizes uses at 14. It also predicts future use at age 19, and it also seems to change following escalating use by age 19. So, one probe of brain function, focus on one brain system, and it's already complicated. And it's hard to extract, definitive cause and effect stories here. So these are the challenges that we're facing in all of this. But this is what we're going to dive into today, and hopefully come out the other side with, I don't know, maybe some sort of insights, maybe not, we'll see. So here's what I want to talk about. So that was just by way of background, cannabis and amygdala function. Cannabis causes, you know what, I was thinking about my slides earlier, kind of looking through them. I think I'm just going to skip this. This is an older study and it's published. We can talk about it at the end if you like, but it's essentially analysis where we're trying to predict in the cannabis naive kids using some machine learning methods who goes on to use cannabis. But I think what I would rather do is focus more on these studies, that putatively suggest that there might be consequences of cannabis use. And the reason why is that I think it's kind of a unique study. We have 9 years of longitudinal data. So we can look at both adolescent exposure, but also at young adult exposure. And I'll share those results with you. And then, although I shouldn't, because it's not only is it not published, it's not even written up yet, we are trying to look at this in the ABCD study. So I'll share some very, very preliminary findings with you from that. And then we'll pause and take questions. So again, I don't need to elaborate. Adolescent development, substantial physical, emotional, and intellectual growth. The slide on the bottom is probably, you've seen it 100 times. Lots of psychiatric disorders emerge during this period. Lots of interesting brain changes are happening during this period. That's just another example showing the sort of, if you will, normative longitudinal developmental changes that we see in things like gray matter volume, or indeed we also look at cortical thickness, surface area, brain function, those sorts of things. Another example just from Dahl-Felferbaum, just again showing that there's a lot of brain changes happening during this adolescent period. And as I say, with regards to given the increased numbers of the CB1 receptors, the anxiety is that, you know, this plasticity of the adolescent brain might make it especially vulnerable to any, you know, detrimental or any effects, good, bad, or different, of cannabis exposure. Okay, the study I'm going to talk about first, we'll talk about the ABCD study later, but for the most part, I'm going to be talking about this project called Imogen, which is not as well known. It's not as big as the ABCD study, but it has the advantage of having about a 10, 12-year start on the ABCD study. So what we have in this project is, you know, lots of neuroimaging, so brain structure, some diffusion imaging, but also, you know, fMRI studies. I won't talk about any of the fMRI stuff today, but, you know, we have a motor response inhibition task, a reward task, and then that social processing angry faces task that I mentioned at the front end. And all the sample was recruited at age 14. Lots of data. We get, you know, genetic data. I don't think I won't be talking about that much either, but, you know, we have it. And then, you know, lots of variables on all the things you might imagine: drug use, personality, clinical symptoms, cognitive abilities, and so on and so forth. But the kicker, and certainly for a dozen years ago, I mean, this was a notably large sample. So we recruited 2,014-year-olds. And the really nice thing about it is that we had follow-up imaging at ages 19, and now again at age 23. Obviously, there's been a lot of attrition. We have about 1,500 participants still in the study. But, you know, it's 1,500 participants with 3 imaging time points from 14 to 23. So it's a very valuable data set that we use, and it's going to be my focus today. Obviously, with the baseline imaging, the baseline battery, we can do interesting things like try to predict who goes on to use cannabis or develop, you know, an assortment of mental health issues. That's the stuff I'm just not going to talk about today. So I'm just going to skip, close your eyes, avert your eyes, and we'll just pretend it never happened, just for interest of time. But if you want to chat about that, we will. But the other thing we can do, of course, is we can look at possible consequences because we have these longitudinal data. So that's what we're going to focus on now. So first, we're going to look at this 5-year longitudinal data. So the age 14 assessment, and then the neuroimaging and the assessments that happened again at ages 19. So that's the first focus here. Okay. We tend to focus on brain. Well, we also look at function, but for now, I'm going to focus on brain structure. This is just, you know, a little bit of background. You know, we know that there are these substantial changes in dendrites, as well as, you know, pruning processes of the dendritic spines. We know, and this is actually from a paper just published a few years back. This is from Yasmin Hurd's group. We know that cannabis exposure seems to impact on these processes. You see here, there's an altered dendritic tree with sparser branches in those rodents that have had adolescent exposure to cannabis. So this rodent model suggests that THC exposure may have accelerated the pruning process, possibly removing some spines, as it says there, that otherwise would have persisted. So that's kind of the part of the foundation for this animal research that suggests that there might be detrimental effects of cannabis, of THC, on some of these maturational neurodevelopmental pruning processes. So for now, that's why we're focusing on brain structure. What we did in this study, so we identified almost 800 19-year-olds, so 450 females, 249 males, all of whom were cannabis naive at 14, but they reported cannabis use by age, sorry, I think I said that wrong, all of whom were cannabis naive at age 14, but reported use by age 19. So we have, if you will, a clean cannabis naive baseline and then use 5 years later. And we're simply testing to see if cortical thickness correlates with the amount of cannabis that they used in those intervening 5 periods. Again, this is the distribution of cannabis use at age 19. Again, nobody has, you know, cannabis use disorder. This is, if you will, I don't know, probably typical recreational cannabis use that, you know, varies in its amount. So hopefully that makes sense. So basically, this is a very simple analysis. There's nothing too sophisticated here. We're looking to see if brain changes in cortical thickness are correlated with the amount of cannabis use that that the kids had in the intervening 5 years. Okay, and this is what we see. Just to unpack this just a little bit, the key test here is this age by cannabis interaction. We expect and we see a main effect of age. So there is, as I was showing you for those previous studies, there is cortical thinning happening during this 5-year period. So there is a main effect of age. What we want to see is if that developmental trajectory, that age effect, is moderated by cannabis use. So is the age effect influenced by the amount of cannabis use that the kids are using? And that's exactly what we see, and the significant age by cannabis interaction. And we should just pause and kind of just imprint for now just the brain map, because we'll be coming back to it later, because it's relatively straightforward. It's almost entirely prefrontal cortex. It's largely, you know, these medial prefrontal wall, left and right side, some dorsolateral prefrontal cortex as well, but it's a heavily prefrontal cortex effect. We're pretty I'm going to make the case. I mean, you know, one can tie oneself in knots trying to avoid causal language. So if I slip into talking about, you know, cannabis effects, just bear with me. But, you know, so one thing we can do to unpack this is if we look at just age 19 and cortical thickness, so just how much thickness there is at 19 and correlated with the cannabis use levels by age 19, we see essentially the same map. If we do the same thing at age 14, we don't really see anything. So again, this suggests that this is a change in thickness that is correlated with the cannabis use and not a pre-existing difference at age 14. As I say, it's a dose-response association. So, you know, these are the sorts of, if one wanted to make a case that this is a causal effect, you know, you'd want to see that temporal order. It's nice to see a dose-response association. So this is just showing you the percentage change, the annual percentage change in cortical thickness as a function of the amount of cannabis use in that 14 to 19 period. And you'll see that there's a, you know, noisy, but a linear association there. The effects persist when covariating for alcohol. So top left is the first slide I showed you. If we controlled for self-reported alcohol consumption, essentially the effects don't change at all. We did a bunch of follow-up analysis in response to a concern about this that are there in the reference if you're interested. So it doesn't seem to be alcohol driving it. This is a busy slide, but let me just unpack it because this will become later kind of an overall thinking about it. What we have here is three things. So we have the brain regions that are showing, if you will, this putative cannabis effect. We then also have brain regions that are just showing an age effect. Brain regions that are just showing the amount of thinning over those 5 years. And the two are correlated. So essentially, on a sort of vertex by vertex level, where we show the biggest cannabis effect is where there is the biggest developmental change. And then finally, on the right-hand side, we have, courtesy of Cyril D'Souza, we have a PET map of where the cannabinoid receptors are. And that map is also correlated with the cannabis effect. So where the largest cannabis effects are, this age by cannabis interaction is correlated with where the CB1 receptors are. So again, it all maybe kind of converges on suggesting that this may be an exposure effect. So just to, hopefully that's clear, just as it says on the bottom there, areas showing the greatest cannabis effect appear to be regions that are demonstrating the greatest degree of age-related change. So they're the most changeable in your brain during that period. And also on average are showing the greatest CB1 availability. Okay. For those of you who are interested in these sorts of approaches, we were just chatting earlier about, you know, kind of big data machine learning methods. We have played with some of these Bayesian causal modeling. I've actually 2 slides in this. This is the simpler one. The next one's going to be a bit more complicated. But basically, essentially what this is, you know, you enter all these variables in the model, and these are all the variables that you can see. So PRS is the polygenic risk score for cannabis use, and then the CUD is a polygenic risk score for cannabis use disorder, age, sex, handedness, measures at age 14, the thickness in some of these brain regions that we're interested in, and then tobacco and alcohol use, and then again at age 19. And essentially what it tries to do is come up with is by looking at the patterns of correlations and partial correlations and the covariance structure within the data. And again, all of this these are essentially correlations, associations. but it tries to fit a model that best explains the data. And you run this multiple times, and there are multiple algorithms, and we tried all of them. And then it tries to identify what it's skittish about using the word causes, so it uses the delightful term a directional association, but not a cause, to try to fit the data best. And what I'm just doing here is thresholding this so that you're only seeing the associations that survive in 90% of the iterations, because you run this multiple times. And then the strength of the line and the arrow direction kind of tells you what the model concludes to be the best set of directional associations. And just to unpack this, I mean, some things, you would like to see. So the thickness level in the dorsal prefrontal cortex at age 14, unsurprisingly, is related to the thickness level at age 19. And it suggests that the best way to think about any association between the two is in this direction, that the thickness at age 19 is influenced by the thickness at age 14. Seems plausible. Tobacco use and alcohol use it finds to be associated, but the thinness of the line concludes it consistently finds these two to be related to one another, but it's quite ambivalent as to whether tobacco use is causing alcohol use or vice versa. Alcohol use at 14 is related to alcohol use at 19, tobacco use at 14 and 19, and so on and so forth. But the critical test for our purposes is this one. The model repeatedly concludes that the best way to make sense of these data is to assume a causal association, a directional association from cannabis use to DLPSE thickness, and not the other way around. The slightly more complicated model is this. Reviewers asked to see a few more variables included. So we added childhood trauma, socioeconomic status, puberty, ADHD, and so on and so forth. Again, the associations that are being preserved here are those that show up in 90% or more of the model, 90% or more of the simulations, the models, and then the arrow tells you the direction and the directionality, what percentage of the models. So again, to kind of try to unpack that, ADHD symptomatology at age 14 in 100% of the simulations was related to ADHD symptomatology at age 19. Moreover, the directionality was always in this direction, which is plausible. Let me just go back. And again, it's always finding an association between tobacco and alcohol, but the directionality again is unclear, and I think that's kind of consistent. You'll see these other associations that you might expect, but again, the critical one is that the model concludes that the best fit to these data is for cannabis use to be related to DLPSE thickness. And just actually to step back to put this in context, I mean, the way I think about this is it's nigh on impossible to prove from human studies that cannabis, causes brain changes, because we obviously can't do the experimental test. So what we can do is try to look at all these converging models, converging pieces of data to then, help us come to what might be a reasonable conclusion. And so, some people really like these basic causal modeling approaches. Some people don't like them, but, I throw it out there as just another piece of evidence for your consideration. Okay, I feel like I'm throwing a lot of information at you, so why stop now? The other question that we ask is this age 14 to 19 use, are there any cognitive or mental health consequences? It's one thing to show these accelerated thinning in brain regions, but is there a consequence? One thing we did see is that cannabis use by age 19 was significantly associated with CAPES. This is a measure of psychotic symptoms. Cannabis use was related to CAPE scores at age 19. However, it's a little bit ambiguous because we didn't administer the CAPE in the imaging study at age 14. So we don't really know what their pre-existing CAPE scores were. So we have to live with that. Impulsivity, though, we do have. So what we did see is that accelerated, apparent thinning in the right dorsal medial prefrontal cortex was related to attentional impulsiveness. This is from the Barat impulsiveness scale at age 19. And there's actually an interesting mediation analysis that shows that the change in cannabis use, so from age 14 to 19, its relationship to attentional impulsiveness at age 19 was mediated in part through the thinning in that right dorsal medial prefrontal cortex. So it's a bit of a mouthful, but just to reiterate again, that association between cannabis use and attention and impulsiveness seem to be mediated in part by the thinning, by the amount of thinning in this brain region. Okay. Take a pause, let you gather your wits before I throw yet even more information at you. You see, you're going to thank me for having skipped some of the earlier stuff by the time we get done. So those are the 5-year longitudinal data. The next I want to chat about is the 9-year longitudinal data. Again, we're in this nice situation of about 1,500 kids. We have brain scans at age 14, 19, and 23. Background, I don't think I need to tell you this, but there's suggestions that cannabis use might be serving as a gateway drug. How exactly you want to conceive of that, what the mechanisms are, is unclear, but certainly there's a lot of epidemiological data that would support that early cannabis use is related to subsequent use of more cannabis and also other drugs. Again, cause and effect. And also, again, this just as well as I do, lots of association between cannabis and mental health, anxiety, depression, but especially, with psychosis. So again, lots of epidemiology that suggests that there may be some sort of association or causal association, perhaps, between cannabis and his mental health. So these are the things that we can potentially address with these 9 years of longitudinal data. So there's two sets of questions we can come at here. So the first of these adolescent users. So again, those kids who were using from 14 to 19 that I've just been talking about that show this prefrontal accelerated thinning, what happens to them by age 23? So do those adolescent effects persist? Are those adolescent effects related to subsequent drug use? And one thing to bear in mind, and this won't surprise any of you, is that those kids who are using from 14 to 19, they continued using from 19 to age 23. A few stopped, but unfortunately not enough to study that as a standalone group. But those are questions we can ask about those adolescent users. But now we can also ask about young adult users. So what about those kids who were naive at 14, who were naive at 19, but then started using between 19 and 23? Do we see any brain changes associated with them? Are those brain changes similar to the adolescent users? I'll just asterisk here because I think it's kind of getting interesting, because now, cannabis use between 19 and 23, we are getting into a, late adolescent, young adult age range that is, straying in, as it says here, into the age range of legal use or decriminalized use across the country. So it's an interesting thing for us to be investigating, I think. Okay, so let's start with the first one. Those adolescent users who had shown this prefrontal thinning, what happened to them when we came back and measured their brains at age 23? So to what extent is adolescent cannabis use, so the use from 14 to 19, related to cortical thickness at 23 years of age? That's the first analysis we did. So the same independent variable as before, how much use from 14 to 19, but now we're relating it to cortical thickness at age 23. I hope that makes sense. And what we see is very similar effect to what we had seen before. So very similar map to the accelerated thinning by age 19. Here we're now looking at age 23, and we're seeing that adolescent amount of use is correlated with age 23 thickness. Now, the one thing that, maybe makes this a bit more interesting is that this holds when controlling for past year cannabis use at age 23. So one possibility is that this effect that we observed at 19 actually persists to age 23. That would be one interpretation of this. We see a number of interesting mediation analysis. So it says they're 22 years. It depends on exactly the sample. It's right on the age on a mean of 22 and an age of 23, but it's the same group. What we're looking at here is, again, the amount of cannabis use from 14 to 19. Is that related to cannabis use at age 23? And that direct association, or rather, is that association mediated in part by those cortical thickness changes that we had seen by age 19? So the question here, if I can try to be just very causal, because it just makes it easier to think about, if cannabis use from 14 to 19 is changing your brain, does that change to your brain potentially have any effect on subsequent cannabis use for 3-4 years later? Again, I'm using very causal language there, but just to hopefully kind of clarify the sort of mediation chains that we're testing for. Anyway, the point being, as you can see, that there is a significant indirect effect. So cannabis use 14 to 19 is related to cannabis. I jumped ahead. Is related to cannabis use at age 23, and that effect is mediated in part by these brain regions that were showing the accelerated aging, the accelerated thinning that was associated with the adolescent cannabis use. That's true for cannabis use. It's also true for cocaine use at age 22, 23, and it's also associated with ecstasy use. So that's kind of interesting. If this gives us some sort of insights into some sort of neurobiology that is relevant to this gateway mechanism. Okay, now let's just flip to the young adult users. I hope I'm doing okay on time. Hopefully I am. Now we look at the young adult users. So different sets of questions. So what about those new users who start after age 19? So similar analysis, but now we're looking at age 19 to age 23 data, and those who are cannabis naive. These are the amounts of cannabis use between 19 and 23. Again, kind of a similar distribution to what we had seen before. Here we have 478 participants. And here's what we see in this analysis. So we are seeing brain regions that are showing accelerated thinning from 19 to 23 related to the amount of cannabis use between 19 and 23. But the thing I'd like to draw your attention to is that that's a quite different pattern to what we had seen previously. Previously, it was mostly prefrontal, especially along the midline. Here, it's a sort of, posterior cingulate, temporal region, mid-cingulate, and some posterior cingulate precuneus, temporal regions, and then also this ventromedial prefrontal region. So quite a different neuroanatomy. Just quick aside, for those who are interested in the methodologies, one thing to note that if we were to simply do a correlation between cannabis use by age 23 and cortical thickness at age 23, nothing survives FDR correction. The only way that we can detect this effect is by having the baseline measure, the age 19, by having that change score from 19 to 23. It's the change score that's correlated. And so even with, the guts of 500 participants, we still don't have enough power to detect effects at 23 alone. We need to have the information because, there's some variability in their age 19 cortical thickness. So again, just to make the methodological point that to unearth these effects, you really need longitudinal rather than cross-sectional data. And that just harkens back to my earlier point that we don't have enough longitudinal data sets to study this. Couple of things just to flesh this out. Are those young adult changes associated with mental health symptoms? So it's a bit small, but essentially what we're showing here is that, so for example, in this temporal region, there is an indirect effect between the change in cannabis use mediated through that brain regions, that temporal region's thickness change, and CAPE, this measure of psychosis symptoms. And again, that's, controlling or including in the model all these other variables, including baseline thickness, baseline CAPE score. So the change in cannabis use through the ROI thickness change is related to the change in the CAPE score. That also holds for the CAPE positive score, and it's not significant. But it's close for anxiety, mood and anxiety symptomatology from the Strengths and Difficulties questionnaire. So again, some mental health associations with these observed brain changes. Cool. Okay. I will finish with a quick teaser on what we're seeing in the ABCD study, and then I will stop and gladly take your questions. Like I said, these are brand new, but it's always just more interesting for me to tell you about what we're doing currently than to tell you about stuff that's already published. So there's only just two slides, maybe three slides, so this won't take too long. What we've identified, so there's actually not an awful lot of self-reported cannabis use in the young ages of the participants in the ABCD study. But what we've done, it's not a huge sample. We start off with 12,000 kids in the study, and we've whittled it down to just 57. So 57 kids who reported 4 or more lifetime uses. This is 4 lifetime uses of cannabis with onset between the years 2 and 4. So we did that deliberately because we wanted to have a cannabis naive baseline scan that was at ages 9 and 10, a cannabis naive year 2 scan, and then cannabis exposure between years 2 and 4. And so this will enable us to see if there's any changes between years 2 and 4. Were those changes already happening when we look at year 2, when we look at baseline to year 2? Oh, that makes sense. And then we identified like with a 3-to-1 matching comparison kids that were matched on age, sex, puberty, site scanner, and then a couple of socioeconomic variables. The groups did not differ on the CBCDL internalizing, externalizing, or attention scores. And also there's relatively no alcohol or nicotine tobacco use in these samples. So it's if you will, a relatively clean, that's the right way to put it, cannabis using group that have exposure between roughly, ages 12 and ages 14. And that's what we're looking at here. These are the maps. This is looking now, interestingly, at surface area rather than cortical thickness. I think we see the same effects for volume. The effects I'm going to show you, and caveat, we are seeing significant effects with FDR correction, but we have limited our focus to just prefrontal regions of interest. Based on the results that we have already from the imaging sample, we thought it reasonable to, have a sort of hypothesis-driven approach, reduce the amount of multiple testing. So we're just looking at these frontal ROIs, and we are seeing a number that are showing an interaction, again, that age by cannabis use interaction, specifically from ages 2 to 4. To show you what that looks like, for the most part, it looks like this. I mean, not always, but essentially baseline. So red here is the comparison group, blue are the cannabis using group, looking at surface area at baseline, surface area year 2, and the surface area at year 4. And you'll see this, decrease in surface area during this window of time in which the kids started using cannabis. And that pattern is mostly recapitulated. This is a bit of an exception, so I'm not sure what's going on there. But that's the pattern that we're seeing at the moment. Okay. I am almost done. So just to wrap up, I really want to flag Matt Alba. He's really taken the lead on these cannabis analyses of both Imogen and the ABCD samples. So really, I'm just parroting all the good work that he has done. The cannabis risk factors, again, apologies, I didn't talk about this, but hey, I've spared you the gory data and just jumped right to the conclusions. So you can thank me for that. But with regards to the cannabis use associations, we are seeing evidence of brain changes arising. I want to be careful with the causal language, arising from use in early adolescence and young adulthood. This early adolescent exposure, so 14 to 19, seems to be related to accelerated cortical thinning, especially in the prefrontal cortices. Impulsivity, this early adolescent exposure is related to impulsivity, and this seems to be mediated by the right dorsomedial prefrontal thinning. It seems to be related to subsequent drug use, mediated by cannabis-related effects in lateral PFC. The early adolescent exposure effects may persist into adulthood. That's what the data suggest. Cannabis use in consequence in young adulthood is related to accelerated thinning in the temporal, paralimbic, and ventromedial prefrontal areas. And as I've just shown you, these brain effects might mediate increases in psychosis and in mood anxiety symptomatology. Last slide, putting all this together, we are seeing, I'm sorry, I didn't make this point, in the adolescent exposure analysis, I showed you that the brain regions showing the biggest cannabis effect are regions that are showing just the biggest developmental change, just age-related changes from 14 to 19. The same is true for the age 19 to 23 exposure. The brain regions that are showing that distinct pattern of cannabis associations are also brain regions that are showing a lot of changes, just developmental changes. So these different patterns together, it suggests that the changes that arise might be related to ongoing maturational changes. Those brain regions that are changing currently, that are most plastic, are the ones perhaps, so again, apologies for overly causal language, but those brain regions that are showing the most maturational change are the ones that are showing the biggest cannabis effects. And if that holds, then this might give us some sort of a handle on why you might see different effects depending on the developmental period you're looking at, and also maybe explains maybe individual differences. A brain region that's changing is perhaps vulnerable to the effects of cannabis, but if you happen to be an individual where that brain region is not changing, you may not be as vulnerable. So this may help explain developmental and also inter-individual differences, but this is what we're trying to pursue with it.